Welcome. I'm Dean Kereiakes, President of the Christ Hospital Heart and Vascular Institute in Cincinnati, Ohio, clinical professor of medicine at The Ohio State University, and deputy editor of JSCAI. I'm here today with Jorge Sánchez from the Hospital Universitario Polytechnic in Valencia, Spain, Hector Garcia-Garcia from MedStar Washington Hospital Center in Washington, D.C., and Adnan Kastrati, who's a professor at the Heart Center in Munich, Germany. We're here today to discuss a paper, Small Vessel Coronary Artery Disease, the Rationale for Standardized Definition and Critical Appraisal of the Literature. And I want to start by asking the first author of that paper, Jorge Sánchez, to succinctly present the nature of the problem, the hypothesis, findings, and recommendations. Welcome, Jorge.
Thank you very much for the introduction. It is a great pleasure to present on behalf of the small vessel investigators the rationale for the standardized definition and critical appraisal of the literature, which has been recently accepted for publication in the Journal of the Society for Cardiovascular Angiography and Interventions. And I would like to thank all the co-authors for the contribution to this manuscript. Well, a small vessel coronary artery disease is present in 1 out of 3 patients undergoing PCI. It is associated, especially frequent in women, in patients with chronic kidney disease, and in patients with diabetes mellitus. And small vessel coronary artery disease is not only associated with an increased risk of clinical failure, but it is also found as an independent predictor of adverse clinical outcomes at follow-up. So, when having a look at the literature, the problem that we face is how do we define a small vessel? And this is very heterogeneous in the published trials. We can see in the table on the left, these are the trials evaluating patients undergoing PCA for small vessels. The cutoff diameter to define a small vessel includes patients with vessels less than 2.75 and vessels less than 3.0. And these values overlap with those of patients undergoing PCI for large vessels that some trials also use a cutoff diameter of 2.75 and 3.0. So this contributes to a high heterogeneity and important source of bias when we want to compare different treatment strategies for the management of these patients. But this heterogeneity is not only found at the clinical research, but also in daily clinical practice. As we can see in this pool from the EuroPCR, almost 300 interventional cardiologists, when they were asked what did they consider a small vessel, there was not a uniform criteria to define a small vessel. So this is why we decided to perform a systematic review, evaluating all randomized clinical trial and prospective single-arm studies that included patients undergoing PCI with drug-eluting balloon or drug-eluting stents for small vessels. We decided to exclude the first-generation drug-eluting stents, such as Cypher, Taxus, and Endeavor. So, after the screening of the trials, we included 25 studies, and these are the results for the patients undergoing PCI with drug-eluting stents. As we can see, there was an important heterogeneity in the follow-up that ranged from 12 to 16 months. Also, very few trials included patients with a cutoff value less than 3, and also few of them included patients with a cutoff value less than 2.25, and also the way that the vessel size was evaluated was very heterogeneous, that it ranged from QCA visual estimation or even the diameter of the stent that was implanted. So for all these reasons, all this heterogeneity, we were not able to pull the data, and as you can see, in the paper, you can find we provided the median event rates for TLR, TVR, TLF, and AMI according to the different vessel size. When evaluating patients undergoing PCI for drug-eluting balloon, this is the result. These are the trials that we included. Also, again, the follow-up was very heterogeneous, and the way that the vessel size was assessed was also heterogeneous, and we were not able to pull the data. So these are the median event rates that are described in the manuscript according to different vessel size. So in order to propose a definition of a small vessel, this is the results of the Dutch peers, a subgroup analysis of the Dutch peers This is an all-comer randomized clinical trial that included patients undergoing PCI with the Resolute or the Promus stent. And as we can see here, those patients with a vessel reference diameter less than 2.5 were associated with an increased risk of target lesion failure at 2 years as compared to those patients with a vessel size less than 2.75. In addition, there were no differences between those with a vessel size less than 2.5 or less than 2.25. Neither there was a difference between patients with a vessel size less than 2.75 or less than 3. Therefore, a cutoff diameter of less than 2.5 was the value associated with an increased risk of events at follow-up. This is why we propose this value as the definition associated with an increased risk to define a small vessel. Although we recognize that most of the way that this vessel will be evaluated will be done on the basis of coronary angiography, either by QCA or visual estimation, we consider that the use of intracoronary imaging to define the vessel size will be of paramount importance in order to reduce the heterogeneity about different studies. So just to conclude, small vessel coronary artery disease yet represents an unmet clinical need since it is associated with an increased risk of events at follow-up. The definition of a small vessel across the trials is inconsistent. There is a high degree of heterogeneity contributing to important bias. And what we propose is that a reference vessel diameter less than 2.5 should be considered as the cutoff value to define a small vessel, preferably measured by intracoronary imaging. Thank you very much.
And then can you make a few of your points that you make in your editorial regarding the different methods used to assess RVD and possibly the reliance on the Dutch peers study as well?
So for sure, it was a great presentation based also on great data, and I have to congratulate the authors for this great job. I have also stressed the need for a definition for small vessel coronary vessels, and the criteria. I think that the criteria that the definition of a cutoff point regarding vessel size should meet one, that this cutoff makes a difference in the outcomes between the two categories under and above this cutoff. And second, and this is more important, it shows an interaction with treatment effect of stent versus balloon-based PCI options. And this is exactly the most relevant contribution of this article, because so we need to focus on the special need of the small vessels in this direction. We have also made a lot of work in this direction. We have done 3 ESAR SMART trials looking exactly at the special contribution of small vessel size in the direction of the optimal treatment option. And the authors have made a huge effort screening more than 1,200 articles and picking up 25 works, and that fulfill both of these criteria. They have looked at the difference in outcomes between small vessels and bigger vessels, and they have looked also at differences in outcomes between small vessels and large vessels regarding the treatment option used, for example, DCB or drug-eluting stents. I think that the Dutch peers is an important study, but on the other side, Dutch peers failed to show a difference in outcomes between small vessels and larger vessels as they look at the comparison between sotagliflozin and everolimus eluting stents. So the other question here is intravascular imaging. I have been critical in this direction. Because this reminds me actually to a debate I had 12 years ago with a very nice colleague of mine. I had to defend drug-eluting stents. He had to defend bare metal stents. And I was in a more comfortable position for sure. And my colleague started his presentation saying, oh, it's a pity that I have to defend a fast food restaurant against a Michelin star restaurant. So I am not against the use of intravascular imaging. For sure, it provides the most accurate measurement of vessel size. But the problem is that it is used not very frequently. So the data in Europe and US shows that it is used in less than 10% of the procedures, depending on the indication, depending on the vessel location of the intervention, etc. But I don't think that alone this contribution in accuracy in measuring small vessel size will also motivate us to use it more frequently. On the other side, the whole paper is based on criteria of angiographic measurement of vessel size, and so you recommend a measurement based on intravascular imaging. That means, and you also agree that there are differences in this measurement. So, in the best case, you need studies to show that this 2.5 millimeter stands also for intravascular imaging measurements. But I know on the other side that you have done it on the pressure of the reviewers. And I will say not always the reviews are positive or are bringing something positive for the article in many cases. So, but on the other side, it's a great study, and so I congratulate again the authors for this. We'll have such a cut-off point to be used in future studies comparing different strategy options in vessel depending on the vessel size. Thank you.
I think it's a great commentary. You know, I think many of our younger viewers may not even recall the fact that the pathway for US FDA approval of a coronary stent less than 3 millimeter diameter for years was called abrupt and threatened closure, ATC. It was not a stent approved for elective deployment in vessels less than 3.0 millimeter. That's because a bare metal stent had greater late loss than a balloon at that time. Now, I'll ask the authors, Dr. Garcia and Dr. Sanz, that, you know, I learned something in the Absorb-3 trial. There's a visual estimate of 2.5 correlates with a QCA measurement of 2.25. You've tied your definition to intravascular intracoronary imaging, as Dr. Kastrati has pointed out. At the end of the day, pragmatically, don't you think we're going to be visual estimate 2.5 and know that that correlates with a QCA of 2.25, particularly with the challenges of doing intravascular imaging distally in more tortuous small vessels? I'd like to hear from both of you.
Thank you. First, I'd like to acknowledge the leadership of this new journal, JSCAI, for recognizing the need of such a review paper. And thank you for having the opportunity to get this interview, because we can clarify points like the ones you are mentioning right now. Indeed, the differences between visual estimation, quantitative coronary angiography, and intravascular imaging are very well recognized in the Absorb trial, but in many other literature pieces. And we know very well, and you mentioned already the one difference between visual versus QCA, but we also know very well the difference between angiography, QCA angiography, and OCT and intravascular ultrasound. They are very well recognized. I think what the paper says is, and I think Adnan Kastrati mentioned it already, and I don't want to be redundant, the most accurate and reproducible methodology for measuring vessel size is intravascular imaging, period. However, practically speaking, this will be done mostly on visual or QCA estimations. Whenever available, of course, the ideal would be to really document the size based on the intravascular imaging. However, practically speaking, this would lead to very few cases done with intravascular imaging. The definition, of course, expands and extends the use of 2.5 as cutoff. I would say nearly irrespective of the methodology that you would want to use. Of course, acknowledging the fact that with visual estimation, you would have great variability across the interventional cardiologist. And with QCA, we know we are always undersizing. So it is not a perfect definition, but there was a need for a definition. And I think this is the best compromise that we could bring on the table. A 2.5 cutoff that could be, again, in summary, estimated by any means. However, when if available, preferably use intravascular imaging.
Excellent. George, would you add to that?
I think it was all said by Hector. I think this is the idea. The idea of the trial was to propose a definition associated with an increased risk of events. We found the 2.5 as the cutoff value. And in order to reduce the heterogeneity, the best way would be to use intracoronary imaging, though from a practical point of view, we acknowledge that a quantitative assessment by coronary angiography will be the way that most of the trials and most of the interventional cardiologists will be based their decision in the future.
You know, I'm struck for all three of you. The curves for time to event are divergent over time. So testing new technologies, whether it's DES design for small vessels, which we'll get to in a second, or it's drug-coated drug-eluting balloons, that the difference between devices will become more pronounced over time. And I think you saw this in the pre-specified bioresort 3-year follow-up and the SCAR data after 2 years. And in your data, these curves continue to widen. How do you see trials in the future designed for testing, optimizing stent design for small vessels or stent versus drug-coated balloon? The duration of follow-up, I think, will be very important. Adnan, would you comment on that?
I think that this is a question for Hector better. So what he thinks about the future study based on this cutoff point, how we should design a study to get out the best strategy for the small vessel size. I would say that we should invest in two directions. What we have so far is we have very good results with DCB in small vessels. Also, in our study here is a Desire 3, we have seen also a reduction of myocardial infarction as compared to drug-eluting stents with DCB. On the other side, we have also the experience with our zero stent, for example, which has a different strut thickness depending on the stent size. So I mean that in small vessel, we should use the strategy with less metal, be that drug-eluting balloon or be that a very thin strut drug-eluting stent. But it should be shown. And for me, the best study design would be to include all patients and to see whether there is a treatment effect between these two categories and the treatment options. Only in this way we can convince people in using a specific option in patients with small vessels.
Excellent. Hector, would you add?
Yeah, I would only add, I love the study design proposed by Adnan. I think we should be inclusive, so we should try to include all different vessel sizes across the spectrum in the coronary vessels. And I like the idea of using a device that have different strut thickness and design depending on the size of the vessel. So he mentioned Orsiro. But there are some other technologies. So another also produced by the same, manufactured by the same company is the Magmaris device. So now it's a bioresorbable magnesium scaffold. Depending on the size of the vessel, the strut thickness varies. And so that's another appealing alternative as well. So basically you customize and you tailor the stent and the platform strut thickness to the vessel size, which really gives you this flexibility and the opportunity to see if this is a differentiator in the outcomes. But I like to touch base upon the drug-coated balloon because Adnan was very right pointing out that this is a therapy that has demonstrated very good results. I think, I'm always in favor of very long-term follow-ups because we need that data. But we have to remind ourselves that the drug-coated balloon releases the drug, and this drug stays in the vessel wall for a very short period of time. And we cannot dream that a therapy delivered by a drug-coated balloon would have effects over 5 years. I think for drug-coated balloons, the study design should be somewhat shorter term or mid-term. And I don't think we could dream that drug-coated balloons would be winning. And as you, Dean, was pointing out, that the curves were widening over time. I don't think we can dream about that with the use of drug-coated balloon. So I think one very specific study design would be when we think of using drug-coated balloons, because those would require a somewhat shorter long-term follow-up.
Yeah, that's an interesting point you raised, Hector, but I would point out that the concept of leave nothing behind makes you more immune to stent fracture, which is a potent stimulant of restenosis and thrombosis. When Steve Ellis, myself, and Greg Stone presented for the IDE of the Absorb trial, one of the data points we used was 1,500 patients, Tom Stuckey, Bruce Brody, Moses Coonan Hospital. They were treated with STEMI with either POBA, bare metal stent, or first-gen DES, and they were followed for 9 years. And they did a landmark at 1 year. To 1 year, stents reduced stent thrombosis and target site thrombosis, but beyond 1 year, from 1 to 9 years, the balloon-treated segment was more inert, quiescent, and the stented segment had more events. So the concept there, and I think many of you remember that paper, is an interesting observation, very provocative, that leaving nothing behind, medicating the vessel, as you landmark it and get more away from the intervention, should accrue fewer events related to the device itself, because there is no device left behind. Anybody want to take that on?
Indeed. Let me just reply to this point. What I meant to say, what you are testing in this particular scenario is the use of drug-coated balloon plus natural history, because the effects of the balloon are good for the short term. What happens beyond, it is already natural history, and it would depend on the control and modification of the risk factors, how much statins the patients are taking, et cetera, et cetera. So I think it's a combination of both natural history results and the short-term effects of the therapy.
But I think this is exactly what we need. Just do not leave behind. This is the concept. This was also the concept of bare metal stents. That's why with bare metal stent, we have expected always a plateau in the long-term results, because you need the antiproliferative drug in the time in which the process of restenosis is more active. And that's it exactly. But I would also point out to another. So what the small vessel studies have shown is that you cannot avoid crossover to stents in a part of the patients. We have found it between 20 to 40% in our studies. 40% it's maybe exaggerated, but 20% it's practically something that we see. And the hesitation has been before due to the recommendation of the company producing the drug-coated balloon. They said at the time, please don't combine it with drug-eluting stents. And this has prevented the larger use of drug-coated balloon, because you know that you have to use some stents in these patients, and you are prevented to use drug-eluting stents. You don't want to go back to the bare metal stents, and that has prevented. But in our experience, I didn't see any negative effect of the combination of drug-coated balloon with a drug-eluting stent. And this makes us to be on the safe side. If there are dissections, you can use it. So even in the small vessels.
The stents are not unidimensional. You guys are talking about ultra-thin stents, for which there's only one in the U.S. market. That's the Zero. But there's also BioRapid, Superflex, BioMime, and MyStent that have been out there. They're all sub 70 micron.
Yeah, I know.
And I think that strut thickness is one dimension, width is another dimension. which equals volume. And we have to think of stents in three dimensions when we look at small vessels, because there's an exponential impact on footprint, abdominal stretch surface area coverage, also in the ratio of stent volume to vessel volume, based on not just strut thickness, but width. And do you believe that the industry should focus on stents made for small vessels now? Because otherwise, the stent market may shrink by 25+% here, very frankly. And actually, it is shrinking in some countries like Japan. So I'll toss that out there, and you guys can comment.
I don't think that it's the best time to look at this for small vessels. After the ischemia trial, someone would say,
exactly.
Let's be there. The small vessel disease, it doesn't disturb us.
Yeah, no, I fully agree. I was thinking exactly the same. It's very challenging to introduce that concept right now. I think the best approach is what has been mentioned here. One platform that can be used across the different vessel sizes. And one platform that can basically have different stent strut thickness depending on the vessel size where you intended to use it. But let's pay attention to these bioresorbable scaffolds and drug-coated balloons, because they can accommodate also all types of vessel sizes. And the studies are ongoing, and I think we have to wait for that. As you both are pretty much saying, bioresorbables and drug-coated balloons would leave nothing behind. And that concept is very appealing for small vessels. But let's go quietly on this one, because targeting just purely small vessels at this timing point will be very uphill and challenging for sponsors and investigators.
No, but the deal is right in saying that now we have the possibility to evaluate the three-dimensional aspect of small vessel with intravascular imaging. And this might help the design of new devices specifically for small vessels. I agree with that.
I think it's a logical thing when you look at the complexity of small vessels and how much of the lumen volume is consumed with a device that you put into it. You know, until these bioresorbable scaffolds, and I had a great fascination with this in the pivotal trial for US FDA approval of BBS. The problem was it's 157 by 140 micron. And when you put that in a small vessel, it fills the vessel. And the event rates, at least out to 3 years, and it took a long time to resorb, they just created events relative to the Zion stent at the time. So until we're able to manufacture devices that either have thinner struts because of peristrunt shear stress abnormalities and thrombotonicity, and until we have struts that go away, maybe a little more quickly, I don't think we're going to have a bioresorbable device in that space. And that may include Magmaris. Any comment? We don't have Magmaris in the U.S. at this time.
So, yeah, we have used because there is a new generation of Magmaris now. I don't know the exact name because the names are difficult for me. But we have done about 10 patients in the settings of the study. And we have always done OCT in all of them, 10 of them, after 1 year. And it was nothing left there at 1 year. Excellent results. But I know that 10 patients are not enough for saying anything. But it makes me very, very optimistic about it.
I have to disclose my conflict of interest here. I'm doing all the core lab work for the Magmaris across the clinical program worldwide. So Professor Adnan Kastrati does the OCT and he sends it over to us where we actually witness what he just described. And so the results are very promising. There is an abstract at TCT going to be presented. And I mean, just due to the embargo, etc., I cannot disclose more. But that technology keeps on building evidence, good evidence, positive evidence. And I see, let me just say it this way, I see the light at the end of the tunnel for this type of technology.
Now, the new technology that you're describing has a strut thickness less than 100 microns there.
It does, yeah. For the small vessels, yes, for the small vessels.
That's really key. That is fantastic. Well, this is certainly a horizon, small vessel disease that's going to be treated more and more. And hopefully we have better tools to treat it. I want to thank JSCAI for giving us this opportunity. I want to thank Jorge and Hector for putting this together, a provocative paper on small vessel, the definition, and really the analysis of the clinical outcomes that occur with small versus not small vessels. And for Adnan Kastrati, who accompanies this paper with an incredibly thoughtful and constructive editorial commentary. And so thank all of you for looking in and viewing this interview for Journal of Society of Cardiac Angiography and Intervention. Thank you.